So it's my pleasure to welcome you to today's symposium, Preventing Ultrasound-related Infections, a New Priority for Infection Control. My name is John Burdak, and I'm the Head of Clinical Affairs for Nanosonics, and I'll be chairing today's session. So as you well know, I'm sure, ultrasound is now used very widely across various healthcare settings, and it's brought great clinical benefit to many patients. It's rapidly deployed at point of care and emergency departments. It is used widely to guide interventional procedures such as nerve blocks, vascular access, drainages and biopsies, and is used extensively in OB/GYN, urology and cardiology. However, as we increase the use of ultrasound alongside that, we potentially expose patients to infection risk. And in fact, I'm sure you would agree that there's actually a significant challenge in managing the infection control risks associated with ultrasound. So most importantly, this needs to be a collaboration between infection control professionals and ultrasound users, many of whom have a less than ideal grasp on infection control concepts. And so I think there's definitely a role for the people in this room in helping those sonography professionals in using their technology safely. So today it gives me great pleasure to introduce Kath Murphy. Kath probably doesn't need a lot of introduction. I'm sure she's well known to this group, but Kath provides independent consulting services to a range of clinical, public policy and commercial clients throughout the world. Her career has covered senior infection prevention positions within the clinical, government, non-government and professional associations in Australia and internationally. Some of her career highlights include working in the US at the CDC, consulting to the WHO and serving the US-based Association for Professionals in Infection Control, APIC, as a board member for 7 years, and Kath was also president of that organisation in 2010. She's also a fellow of SHEA, the Society of Healthcare Epidemiologists of America. And in 2016, Kath became the first non-North American to be awarded APIC's esteemed Carol DeMille Award for Lifetime Excellence in and dedication to the field of infection prevention. I was actually at that award ceremony, and listening to some of the people in the US speak about Kath and her contribution to infection control was really very impressive. So without further ado, over to Kath. Thank you.
Thank you, John, and thank you to Nanosonics for this opportunity. I'll just clarify my bio and say that it can be much more simple than that. And I said to John, it's actually about Kath does what she loves and loves what she does, and has had a lot of luck along the way, so take that away. Thank you for joining me at this very early hour. It's particularly impressive as we enter into the third day of the conference. For those of you, as always, I'm happy to let you know that these slides will be available, or access to the film of this, or the video that's being made of this today, so please don't feel that you need to scribble. I'd rather you enjoy the presentation in a more relaxed way. So, as always, I need to show you my disclaimer, and please note that I am providing consultancy today to Nanosonics. However, the information is as scientifically valid, reliable and honest as usual. There are a couple of other folk around the world who are doing great work in this area, and I'd like to acknowledge them. Professor Ruth Carrico, with whom I served in APIC on the board, and Roy Burdikin from the United States have both been progressing similar sort of work in the US, and they were kind enough to let me share and use some of their slides, so I'm grateful for that. So, as usual, there's a little bit of work involved in spending the morning with me, and these are the things that we'll be doing together in the next 40 or so minutes. I want to help you understand more about the risk mechanisms and the extent of ultrasound-related infections around the world. And I hope that you'll find that interesting, illuminating, but probably quite scary. Well, that was the way that I responded to looking at this in greater detail. There have been a number of outbreaks, and so I wanted to investigate those a little further with you. We just need to, I think, turn off timings on this slide presentation. We also will be discussing the current requirements of Standard 3, or the current version of Standard 3 regarding reprocessing of reusable medical devices and equipment. That will give you an ability to make sure you're in compliance with that. And then I'll brush over some of the very important points. I won't brush over them actually, I'll spend a fair amount of time on them in the guidance that's been developed for us by ACIPSI and also the Australian Society of Ultrasound Medicine. Now, just so that I can get a sense of your knowledge, can you please just let me know by a raise of hands who's actually read the ASUM ultrasound guidelines in the room? Okay, so again, we have a little under everybody, and that's good because whilst I know you will rush from this talk and go and read those guidelines, it also helps me understand that how I need to present the material that I will be. So let's start by looking firstly at the risks and how these ultrasound-related infections happen and how many of them there are. So currently, what we've found around the world increasingly has been the dramatic expansion of areas in any acute care setting and perhaps even some other settings where ultrasound is used. And this just keeps going forward. Along with that, what we're seeing is the use of and the need for high-level disinfection and sterilisation based on the particular use of the ultrasound device. So we've found that confusion amongst users of ultrasound regarding what type of reprocessing or classification of the ultrasound device for the reprocessing procedure and variations between departments. The other thing is that it's ultimately should be your goal to apply the same standard of care and the same form of reprocessing or the criteria for those across your organisations. And so in all hospital departments, we'd like to think that people were doing the same thing. If I can have the next slide, please. It's probably the better way for these slides to be changing. Okay, I'll take back control of the slide changing. If we look at this in a graphic formation, what we actually see is that the issue is very complex. Sorry, this slide jumping is really difficult for me to manage. We find this increasing complexity of ultrasound probe reprocessing, and how that's happening is that you have a number of different departments, so you have a lot of different departments that are using the ultrasound probes either on the surface of a patient or in intracavity spaces. You've then got a range of a variety of procedures. You've got many different individuals across both of those modalities, and then you have some unique diversifications of Spaulding's original classification for reprocessing. And this, all of these points, but particularly this, I think can lead us to a point where it can all become part of a conundrum, and I hope we'll get some clarity on this by the end of the presentation. So bring in the individuals, and many of you will know that much of the work that we do and much of the remedial work we do is because individuals make poor choices, or the system doesn't allow individuals to practice in the safest way. And then the other confounding and difficult issue for us to address is to actually understand where and in which places in our organisations are ultrasounds being reprocessed. And in large organisations, this could be across many different departments, and traditionally we would have thought perhaps it was only in the imaging departments, but I'll show you through the outbreaks that it's happening in a lot of other places. So just as probably a first take-home message, I'd say to you, after you go back and you do your work on antimicrobial resistance, please then go and do a stock take in your organisation of ultrasound use and ultrasound reprocessing, because you may be surprised regarding what you'll find. For example, we can see in this slide, graphically and simply for the early hours of this morning, the use of surface probes has really exploded to many different invasive and semi-invasive procedures that, for those of us that have been around a long time, we perhaps never conceived that ultrasounds would be being used in them. For example, for placement of central venous catheters, even for the placement of some difficult peripherally inserted catheters. I mean, who would have ever thought that? You know, they're used in transplantation surgeries, in pericardiocentesis, and also in other complicated intraoperative procedures. So if we came and looked at these sorts of procedures with our infection control brains and perspectives, there's clearly different requirements for reprocessing dependent on how these devices have been used, and therein lies the difficulty. So as for all parts of reprocessing, we ask ourselves, you know, why do we need to do this? I believe that, and the literature as well and other guidelines, that we disinfect ultrasound probes for several reasons, and they're listed here. You know, they are often used in invasive procedures, so therefore then carry the risks that are inherent with that. They are used in neonatal populations who have low ability to fight infections. They're also used in procedures where we have to have critical sterile fields, and they're examples where you have a critical sterile field but you're actually not invading the skin. And so if we use our usual ways of thinking about Spalding and his classifications, perhaps we get confused or find it difficult in that situation. Again, we'll clarify that for you well this morning. Then you have the use of these probes in areas where you've got intact mucous membranes, and people sometimes don't think that that poses infection risk. But what we do know is that there's been many outbreaks and many different types of infections that have been transmitted by probes that have been contaminated. And in some cases, they've led to very serious consequence, including death. So let's not be complacent about these risks. And astoundingly, these outbreaks have been reported now for more than 20 years, you know, for almost 25 years. And so it's been a long time in which we've had to address some important issues, but perhaps have been inefficient in how we've done that. So I'll share with you now the detail of some of those outbreaks. This is not comprehensive. In fact, I've had to cut them down for time purposes, but there are very many. And I've classified them this morning in two groups. And the first group are those infections and outbreaks that have actually been attributed to the use of the ultrasound probe itself. So one very concerning one is a case of hepatitis C transmission after a prostatic biopsy. This occurred in France. A 53-year-old male had ultrasound-guided prostatic biopsy. 4 weeks post-procedure presented with positive anti-HVC antibodies and was diagnosed with an acute hepatitis C. Now, would we have ever considered ultrasound looking at this if we were responding from a public health point of view? I think not likely. However, we would have had that approach traditionally. It very clearly became the case that this hepatitis C was transmitted because it was a case of contamination that followed the biopsy, and therefore it should be a good warning for all other practitioners to scrupulously adhere to the recommendations, and in our case they're the ASIPSI and ASUM recommendations regarding existing sterilisation, reprocessing, to use protective sheaths and to verify the integrity of the protective sheath, and to use single-use puncture guides. So again, it starts to becoming a little bit complex. And there you'll see my first use of the term protective sheaths. I'll just say right up front, just as we find with surgical gloves and other gloves, protective sheaths are not infallible. They can tear, they can degrade, and they can have punctures in them that are microscopic. So again, that's good reason for us not to not use them, but in fact to use them with care and a respect for some of their limitations. So, you know, we've had that hepatitis C case. What we then found was in the United Kingdom, they became aware of an incident where the death of a patient occurred with hepatitis B infection, and they suspect was associated with a failure to appropriately decontaminate a transesophageal echocardiograph probe between patient uses. Again, this would have been perhaps difficult to conceive, but certainly happened. And based on that case, the authorities in that particular country issued this alert and had a series of actions that they recommended, complying with best policy and, you know, again, knowing what those policies contain and being able to follow them. So I'd say, you know, you really do need to have a look at that ASUM guidelines. Now, we can hear stories like this and not be moved by them. We go, you know, someone's died from an infection. I'd suggest to you that we perhaps change our line of thinking, because in this case it resonated strongly with me, because in fact that death was a retired nurse. And I don't know about you, but I just find it incredibly annoying that healthcare workers who often spent their life caring for others can become subject to infections and mortality through either patient safety problems or through inadvertent transmissions like this. So, you know, there's the numbers that we see and read about always have a human story behind them. And there she is, the face. Don't look too closely, but no, she's not a relative, but still from our family of nursing. In Scotland, they were responding well to many of the increased problems that we were starting to see, and so there was a landmark Scottish publication that came out showing an epidemiological link between improper ultrasound disinfection and, as a result, increased infection risk. And they found this through mining several Scottish databases. But I think that what's concerning here is that we see the degrees of significance, the levels of significance, and these risk ratios or odds ratios saying that the patient is 41% more likely to have a positive bacterial culture and 26% more likely to be prescribed antibiotics after having had a transvaginal scan, according to the Scottish data. Now, if you think about the other important messages that we've been talking about and have been thematic through this conference, the prescription of antibiotics, we certainly want to try and stop doing that in cases where we can prevent it. So another good reason that we need to enhance our abilities and capabilities in reprocessing. Then you have a similar sort of odds risk here where we have patients being 3.4 times more likely to have positive bacterial cultures, or a patient being 75% more likely to be prescribed antibiotics 30 days after having a transrectal scanning. And, you know, good reason for us being able to give a patient high-level care and safe care that reduces their risk. So let's move now, not from, still procedurally based infections, but those infections that have been attributed to ultrasound gel. Personally, I found this year's outbreak that Ramon Chabon, past president of ACIPSI, reported, I found that just mind-blowing. And then when I read more about these and read a whole lot more about ultrasound gel-related infections, I thought, oh my God, you know, it's an area that we need to be across, because these are just some of the papers. In fact, they're probably not even a third of the papers that are out. And you can see the different places, you know, urinary tract infection, Pseudomonas capacia after transrectal ultrasound-guided needle biopsy, same bug, prostate. We've got others that are in paediatric populations, in neonates, in contaminated ultrasonography, and here, again, you know, gels being implicated. So it's a pretty big problem, and a good reason, again, why we need to do better reprocessing of these devices. So let's move on here. And I'll show you, this is my local hospital, sadly, and you go in there, you would assume that you can go in to this hospital and come out safely. However, in May 27, all hell was about to break loose as they started to investigate the increase in cases of Burkholderia that had been coming up as CLABSI cases. And as Ramon's presented, and I think John even spoke in his presentation about this, across the country there ended up being 9 patients who developed bloodstream infections with that particular organism after they'd had ultrasound-guided central line insertion. So in terms of the issues that I've been speaking about previously, what are the concerning points? The concerning points was that this outbreak was multi-institutional, national, and there may be other cases we're unaware of because the microstaff have not made the important linkages in investigations. The other thing I think it said to me is that I have always believed naively that when something comes packaged sterile, if it's been stored properly and is still within expiration date, that it is sterile. And clearly that wasn't the case. And in this particular case, I would say that that brand or that type of gel was probably purchased based on a commercial decision because it perhaps was less expensive than other products produced in countries where there's probably better good manufacturing process. So it's a complex issue and more power to the investigators to realising what it was, but we also should have been well aware, and as infection preventionists, we should have been thinking about the linkages between ultrasound, between use of ultrasound gel and then subsequent risk for bloodstream infection. And in honesty, it would never have really come up in my thinking had I not, been exposed to looking at these issues in depth. And so therefore, I'd probably assume that it isn't something that you would have spent a lot of time worrying about it at your desks. And I note well that Wendy Beckenham, who, I think, Wendy, you're an author on this paper as well, or if you're not, I don't know why not, because I know you're involved in this. And please feel free to add your views after I finish speaking. Then not only did we have this problem up the road from home, but just 2 months later we had another large outbreak of the same problem internationally, and in this case it actually resulted in the death of 2 patients. So it's a serious problem. It's one we need to be ever present thinking about, and bloodstream infections, as you know, are particularly traumatic, with high morbidity and mortality often associated with them. So the key point here is that when we're working in an aseptic way and we have a sterile field, then every item that gets added to that sterile field needs to be sterile, or if it can't be sterilised, then it needs to have high-level disinfection and then a sterile probe used on it, and that includes obviously ultrasound gel and ultrasound probes. There are many guidelines available to us to make the job of managing and having infection prevention responsibility for ultrasound-related reprocessing. So it's not like you have to go out there and work out what the answers are. What you have to do is sit down and take in these pieces of information and apply them properly and in a way that's useful for your organisation and is based on good recommendation and good science. So when I tried to have that logic or that way of looking at it and putting together the relevant Australian standards that we're required to follow regarding reprocessing, the guidelines that are issued from professional organisations, and then our own national infection control program, this is how I summarise it. I see that those documents say non-critical probes that have contact with intact skin can be cleaned and then followed by low-level disinfection. You then have semi-critical probes, and according to Spalding's classification, semi-critical probes that have contact with non-intact skin, mucous membranes, and or are likely to have contact with blood and body fluids should be cleaned and have high-level disinfection, even if a sheath is used, and that's because of the sometimes questionable integrity of those sheaths. And I'm not saying that they're not well manufactured, but what I am saying is that, like all other things like gloves, they are prone to tearing and micro-perfusion. So if you're using a probe as a critical device, according to our godfather of reprocessing, Spalding, those devices should be sterilised, but there are often issues where they're delicate devices or they're heat sensitive. And so as a result of that, one option we have is that they be cleaned and then they be high-level disinfected and used with a sterile sheath. Now, the use of these single-use sterile sheaths or other forms of protective barrier should never be used as a substitute for cleaning, disinfection or sterilisation, and they should never be used for time-saving or convenience or laziness or lack of the system to support best reprocessing. So we need to use those things sensibly. So let's look more closely here at the use of ultrasound probes in the critical aseptic field, i.e. when either a peripherally inserted central catheter or a CVC are being inserted. As you well know from Healthcare 101, whatever your background is in training, any breach in asepsis will pose a risk, and non-sterile equipment should never be used in a critical aseptic field. When you apply these probe covers, through handling, you are putting in perhaps an opportunity for cross-contamination from the probe, and that's been demonstrated in some of the literature. I've spoken enough, I think, about the potential perforations, tears, or even issues with gaps around the top of these sheaths, and you can see there in different procedures that there are a range of percentages as to how often those breaches or tears may occur. What we know is that before they're used in a critical aseptic field, the probe should, at a minimum, undergo high-level disinfection and then be used with a sterile sheath and only a sterile gel. After the procedure, you're dealing with not only procedural contamination, but also the need to reprocess that probe so that it's used safely on the next patient. So after that procedure, the probe needs to be reprocessed, and obviously prior to reprocessing, it has to be properly cleaned and blood and body fluid and other proteinaceous material removed from that. And other material includes also contaminated gel or even the presence of gel or skin. Failure to do either of those can obviously increase the risk of transmission afterwards. We were lucky because ever vigilant TGA, who are somewhere around here, did a timely recall and issued the relevant safety notices, and there were many opportunities for us to be exposed to this information. And obviously I hope that you all then went running through your organisations and did at least a stock take on the use of these probes in insertion of central venous catheters. So the other thing that it says to me that I've not covered in a slide is the need for infection control, as always, to be having good collaborations with your vascular access teams where you are lucky enough in your organisation to have them. So there's always teamwork involved in it. So from this first half of the presentation, what are the key points I'd like you to take away? Firstly, there's been multiple outbreaks, and I've shown you a solid case for that. They've been wide-ranging, and there've been a range of susceptible patients in susceptible procedures. Treatment or response to some of those infections has been death, but in those where it hasn't been death, it's sometimes led to additional use of antimicrobial agents, which we know is not ideal for the current times that we're in. We know that there's widespread use of these ultrasound devices in many sites within any organisation. The guidelines, in honesty, yes, they're very difficult. They're written by a guideline writer who often doesn't understand what you do at the coalface. But we do need to sit down and synthesise them and interpret them, and I'm happy to have been able to have the opportunity to do that, and I hope the way that I've done it makes sense for you if you're working in a clinical setting. It's always good, I think these outbreaks should inspire us to go and review our current procedures and see that they're timely. And one of the problems we face in infection prevention in this century is that technology is advancing very rapidly, perhaps often more quickly than our ability to understand that technology, understand fully its complications, potentials for risk, and often that expansion of technology and tweaks in different technologies require us to really go back and look at our policies and procedures. I mean, we have been doing hand hygiene for 200 years, but the ways in which we've done it are very different. You know, we have been using ultrasound for many years in this country and internationally, but the ways and the places in which we're using ultrasound now are very different to what they were. So you have to always be on the ball in terms of that. The other good thing about any outbreak is that when we go in and we investigate it, we can often find some other deviations from what we know is best practice infection control. And again, with that, it's incumbent that we go and try and improve infection control overall in the organisation. So what are some of the other problems that are associated with ultrasound disinfection? There's overwhelming evidence, published, anecdotal, many different ways, that disinfection is quite poor. And what we've found, I think even in some Australian studies, that in ED departments, 57% of transducers had blood and 46 of them had bacteria on them across 5 emergency departments and 5 intensive care units in one study. So that's a very high and worrying figure for us to see. We've also seen that, you know, Doppler probes themselves can be contaminated, and there is widespread evidence of poor disinfection practice, probably because it's a complicated process. In another study, even when they've been disinfected with low-level disinfectant wipes, almost a quarter of ultrasound probe bodies were still contaminated. And why would that be? In my mind, and based on my experiences, I would say that that's because wiping brings with it the problem of missed spaces and missed places, just as it does when we're doing room decontamination or room cleaning. And that humans, we're not infallible. The processes sometimes make us do the wrong thing inadvertently. So it's good that, you know, we have these difficulties in process that keeps our minds active, and it lets us give bureaucrats good opportunities to come out with guiding documents like Standard 3. And in the new Standard 3, I wasn't able in time to look at draft of the new Standard 3, or if in fact it's even available, and see what it has to say on reusable medical devices. But what I've used is the existing Standard 3. And what I'll do next year is, when I have access to the draft, I'll make sure that I'll look at this issue, and if there are any problems with it or deviations or new information that comes to hand, and I know that Nanosonics will be on top of that anyway. But in the current version, and let me qualify that by saying the next version of Standard 3 won't be enacted or applied, as I understand it, until January 2019. So there'll be a bit of a catch-up period anyway. So in the current Standard 3, the things that are required of us are that we do risk assessments. So you do need to go back and do that risk assessment and see that you've got that clean, hygienic environment, that you are reprocessing the reusable equipment, instruments and other devices in accordance with both the relevant national guiding documents and the manufacturer's instructions. So time for Kath Murphy to make a confession here, because I know you're friends and you won't have a laugh at this. I'm notorious for not reading manufacturer's instructions, and with anything, you know, if I'm assembling anything flat pack, so I never read the instructions, I'll just go ahead and do it. And there's probably some serious personality fault in people that do that. But if I were working clinically in a hospital, I really would have to say to myself, you know, read those manufacturer instructions. And I've got a couple of slides later on saying to you, you have a right to understand certain aspects about the device. So I really do want to impose upon you, you probably need to go and look at all the ultrasound devices that are being used in your organisation, but not just physically look at them, find the corresponding manufacturer instructions regarding them and follow them in terms of reprocessing. And then when you have devices that are brought into your, or systems brought into your organisation for reprocessing, you also need to read those manufacturers' instructions and have them, I would suggest, available for people to refer to after an initial read. They really are very important. So then you have to have systems within your organisation to enable you to identify patients that have had reusable medical devices used upon them. And I'm sure that there's a variety of ways that Australian organisations would meet that particular criteria. And then, as always, you need to ensure that the workforce who are contaminating reusable medical devices undertake competency-based training. So when I read that, my mind says, well, that means everyone working in central sterilising department has to undergo competency-based training. Let me add to that, a more mature, a more concerned Kath Murphy also thinks that anyone who is involved in ultrasound reprocessing, and there will be people that you perhaps don't even know are involved in the reprocessing of those devices, they too need to undergo competency-based training, and perhaps regularly, i.e. once a year, seems to be not an unreasonable request. So if you're going to educate people on what is required in terms of manufacturers' instructions and what's required in terms of their competency, it's incumbent upon you then to make sure you choose the right disinfection method. So how do you do that? Well, the ways that we do it, probably, is that we would go to the infection prevention guidelines for Australia and the Australian Standard Documents and Standard 3. And I think we're very fortunate because in a very simple way, this document tells us about ultrasound and says, you know, you need to consider them critical devices, and the examples are if they're used in sterile body cavities. So that's well and good, but also think about if they're used in a critical sterile field, which is a bit different and not covered. If we're going to classify them as semi-critical devices, then that includes toes, transrectal and transvaginal probes, and if they're non-critical, then they've been used in non-invasive procedures, or perhaps have been used in other ways that are non-critical. Out of interest, who do you think this is? Okay, I knew none of you would know who he was. It's not a relative. This is the famous Earl Spalding. He's pretty a handsome gentleman, isn't he? And very wise and well accepted for, I think, perhaps over 100 years. So if we use Spalding's criteria, we all around the world, I hear people, you know, Spalding said, it's the universal criteria. Spalding says to us, if a device is critical, or a device is critical if it enters the sterile tissue or it enters the vascular system, and therefore we have to reprocess it in a way that all viable microorganisms are destroyed. So sterilisation seems to be the most logical process there. A device is semi-critical, according to Spalding, if it has contact with mucous membrane or non-intact skin. And in those cases, it requires high-level disinfection, and through that process, all viable microorganisms will be destroyed, except bacterial spores. And C. diff is obviously a bacterial spore that gives us a lot of pain and grief at the moment. If a device is deemed to be non-critical, so it has contact with mucous membrane or non-intact skin, with intact skin only, it can be intermediate level disinfection, and that gets rid of most vegetative bacteria and viruses destroyed, except spores, mycobacterium, fungi, or small non-lipid viruses. And so you then have really a position between low-level disinfection and intermediate-level disinfection. Now, we've loved Spalding, we've followed him, but perhaps changes in clinical practice or the ways that healthcare workers are using some of these devices require us to rethink Spalding's classification. And there are authors around the world that would suggest it is time to rethink this. Michelle Alpha is a very clever Canadian microbiologist, I think, and she too has written on this. So this particular paper says to us that when we use ultrasound for examination across intact skin, what is its classification? Because ultrasound gel is a non-critical item and sterility is non-essential. When we use on mucous membranes or non-intact skin, it actually becomes a semi-critical item. If the ultrasound is inserted through or into a sterile field, it becomes a critical item and sterility is essential. And here are some of the examples of that. So transvaginal biopsy, ovum retrieval, transabdominal and thoracic biopsy and drainage amniocentesis. And you can also have in-use contamination. Expiration dates are always important. So we need to, try and get our heads around what it is. So others more clever in this than I, and me as well, have kind of been thinking about what we need to think in terms of the right disinfection method. And the question is always at the beginning, what are we using this ultrasound probe for? And so think again in a modified stirling. If the probe has contact with sterile tissue or blood and is used during any of these procedures, it's inevitably a critical device and therefore should be sterilised unless it's heat sensitive or too delicate. And then it can have high level disinfection, but of course you then need to use a sterile shield and only ever use gel, which is sterile, confirmed to be sterile and not contaminated. If the probe, however, is having contact with mucous membranes, non-intact skin, so in any of these types of procedures, it's a semi-critical item and therefore should be appropriately reprocessed by having higher level disinfection and the use of a clean sheath. If the probe has contact only with healthy intact skin, such as a transabdominal ultrasound or a surface ultrasound, it definitely is a non-critical item and low-level disinfection should be sufficient for its reprocessing. So 2 ways that I've done that. Now let's look about the responsibilities, because so far it's been all about you, and your responsibilities. Other people are involved and have responsibilities, including the manufacturers of probes. And what they're obliged to do is make sure that in their manufacturer's instructions, they provide you with the proper information for their product. And as such, I would imagine that manufacturers of probes are happy and have some system available for you to phone them or make contact with them to get clarification on this. So, you're their customer once the transaction's been enacted. You're their customer in an ongoing relationship. And they must be able to provide you with information on how their device can safely be reprocessed and used. You also have other rights to ask of them. So, use these rights if you need to. You need to make sure what you're doing is compatible, that if you're using a disinfectant that it's TGA approved. Are there compatibilities between the probe and the cleaning agents? Will the use of a non-approved disinfectant cleaning agent void the warranty on the particular device? And do they have any other information in addition to the data sheet or their marketing materials that they'll develop you? And if they do, I hope you've asked them for that information, and then look at the currency of that information as well. And actually, that could go for any product that you're buying or you're purchasing, not just probe manufacturers. So you also have a similar rights in terms of disinfectant manufacturers, and they have similar obligations as well. So they're obliged to provide you with information, safety and efficacy of their product, very important issues. And it's also your right to ask about TGA approval for what level of disinfection, what is the kill efficacy of that product, what bugs, what logs, are there any workspace or workflow considerations with their product, are there any toxicities that they're aware of either here or internationally. You need to have information on cost and then also disposal. and safe disposal. So there are good relationships out there available between consumers, product manufacturers and disinfectant providers. Another point that I need to raise with you is that the probe handle can also become contaminated, and it too needs to be disinfected. And there have been papers showing problems when this has not occurred. Michelle Alpha, I mentioned her before, it's imperative that guidelines now and policies are updated to ensure that vaginal ultrasound devices have their handle as well as the probe head adequately cleaned and disinfected after every patient use. So here, concerns around transmission of HPV. Other papers have been published showing us that more than 80% of probe handles are a reservoir for infection. Not all probe handles can be immersed in liquid soaks, and automated hydrogen peroxide mist devices disinfect both probe bodies and handles. So there's a unique issue in terms of probe handles, but there are good reprocessing modalities available to us. Have a look about what different guidelines around the world have to say about this issue. There's generally agreement. So I find that validating and good and a safe position. The Scottish have been proactive, the Irish have been proactive, the Aussies have been proactive, and so too have this other group around ultrasound probe, and they all agree that probes are semi-critical ultrasound probes, intracavity or surface, must undergo at least high-level disinfection, even if the probe is used with a probe cover. So follow the guidance, look for it. I've spoken about the Australian document a number of times this morning. I think it's a very sound document. We had good people involved in the writing of it, Thea van der Mortel and Terry McCauley, who's been working in reprocessing for 20, 25 years. Maria was involved in it, and a sound document that well describes the situations we could find ourselves in clinically in Australia. What is its aim and what does it do? It obviously provides a national framework of guidance for reprocessing. It sets and gives life to the minimum standard of practice for reprocessing ultrasound producers, and it also makes good mention of other infections that have come from inadequate reprocessing of these ultrasound devices, where disinfection's been either inappropriate or where the devices have been damaged and therefore not reprocessed properly. All of this is concerning because look at the range of agents that are potentially transmitted. They're not just simple viruses, they're not just blood-borne viruses, they're, bacteria, multiple resistant bacteria. So, this is a very serious issue. Clostridium difficile, a huge problem for us from an infection control perspective, respiratory bugs, and then other protozoa, fungi, and parasitic pathogens. So, I've kept building the case this morning, and thank you for persisting with me, but it's serious when you see such a broad range of organisms. So what are the recommended cleaning and disinfection procedures according to the ASIPSI ASUM document? Cleaning's essentially a prerequisite. A soft brush should be used particularly in grooves and crevices, to get rid of any bioburden in there. All the agents that we use must be on the TGA Register of Therapeutic Goods. Manufacturer's instructions, including compatibilities, must be followed, and safety data sheets should be followed so that staff have personal protection, and as well they need to have equipment stored appropriately, and I would imagine auditing of that is also important. So that document outlines low-level disinfection and the procedure for doing that, saying manually remove all ultrasound gel. Transducer is cleaned using a TGA disposable cleaning wipe or system intended for use on a medical device, or the clean the transducer by using freshly made up solution of cleaning agent at the correct concentration, and rinsing thoroughly is very important. And then use a dry single-use low linting cloth for the drying process. So if you're using high-level disinfection, manually remove all gel again prior to cleaning. Make sure you use a TGA-approved disposable cleaning wipe or system intended for use on the device, or clean the transducer using freshly made up solution and cleaning agent, right concentration, rinse underwater, and again dry with a single-use low linting cloth. If you are involved in this, there are often other... Sorry, I've just skipped slides here on my thing. If you're doing a high-level disinfection, you have to inactivate all microbial pathogens other than the endospores. Make sure you use TGA-approved disinfection methods, follow the manufacturer's instructions, and the available methods that we have access to are high-level liquid instrument-grade chemical disinfectant, automated high-level disinfection systems that are either chemical or light-based, and high-level disinfection instrument-grade disinfectant wipes. Now, I have to say, my experiences with automated systems in many different aspects of infection control, I show a great preference towards them, because things that are automated take out the human factor. They give us standardisation, and through standardisation, greater potential to have good manufacturing process. Every time you bring a human into it, or you bring another step into the process by using, say, wipes and things like that, you bring in a potential for inadvertent breaches or ineffective steps of that particular system. Use of clean water, single-use low linen cloth, filtered or sterile water for rinsing on critical aseptic fields, and then storage in a specific cabinet, or use of a clean disposable cover. So I hope that that's clear. They're a lovely set of guidelines. So what are the other issues that we need to be aware of? And just because of time, I'll try and go more quickly. Traceability is an issue. Any equipment that's been in contact with the patient should be cleaned with a detergent or disinfectant wipe or solution between use, of course. That should happen. We need to have good workflows. Automation cuts that problem out for you, and you do have good workflow with it. Appropriate precautions need to be taken to prevent cross-infection between patient and operator. All users must be trained, and they must be competent, and that should be assessed regularly. All intracavity transducers should be covered with a single-use high-quality transducer cover. And that's an important point, single-use high quality. And I'd say that for gel as well, because clearly the gels that were involved in the outbreaks that were being provided were not high quality. So high quality is an important caveat. The disposable cover should be removed, discarded at the end of procedure, taking care not to contaminate the handle, cable or cord of the transducer. If there are defects, perforations, they may jeopardise the integrity of the cover. And covers used in critical aseptic fields must be sterile and applied in a manner that prevents the contamination of the sterile barrier. And that can be difficult. And again, it's something that users need to be competent in. If you're using gels, same sorts of principles. Limit it to low-risk genital examinations. Don't heat the gels. Follow manufacturer's instructions. And ensure that reusable dispenser bottles are completely emptied, thoroughly washed, dried daily, weekly, according to your infection control practice. Clean all reusable equipment. For procedures that require the use of sterile gel, ensure that only unopened containers, sachets that are labelled and in date and truly are sterile are used. Any portion of a single-use sterile gel packet has to be discarded and not reused for another examination or patient. And it seems, ridiculous to have to point that out, but healthcare workers are particularly resourceful, have always been so, and we've all seen crazy things. So this is probably the most thing that will inspire you, is that, I'm near the end of the presentation, and rather than listening to my early morning voice, as attractive as that is, I'm going to end on a better way, and I really do thank you for your support at this conference and the work that you do to help patients in Australia be much safer. It's almost funereal, but It's not. That's it, we can stop the music. So you've there seen my feet, my mother's hands, the foot of a very precious now 2-year-old to me. And as always, we can be affected around infections and infection prevention at very personal levels. And all families of patients that we care for need to have good care. So I really do sincerely thank you for everything that you do. It's not easy, and if I can ever help you, please contact me. I know that Nano will continue to do great work in spreading the infection prevention message, and I think that will be through availability of this video and the presentation and other educational materials. So thanks very much. Have a great day and wash your hands.
So thank you very much, Kath. We do have 5 minutes for questions, so I think it's a fairly small room. If you just want to sort of stand up and put your questions to Kath, if you have any, that would be fantastic.
That was a fantastic presentation. My name's Susan Harper. I'm the Manager of Infection Prevention, Peter McCullum Cancer Centre. What I did, so that's a whole new lot of learning for me as an infection control consultant. And in our latest accreditation, which was just in October, we know about hand hygiene, we know about antimicrobial stewardship, we know about HAIs, but I had to go on a huge learning curve with the new standards. And, you know, I think the whole issue around the reprocessing, and as you've pointed out today, of equipment that is outside the theatre, that is in many of our specialty clinics or outpatient clinics. And as infection control consultants, we see a workload that needs dedicated time. So I'm not here to trailblaze, because we all know about protected time, but it's something that I'm happy to embrace, because I think it's very easy now that we've got really good evidence. We always need evidence to go forth and start to grapple with how people report up through infection prevention around their cleaning and their auditing and their, you know, surveillance. So thank you. It's given me, you know, the way forward, but also to acknowledge that you're here in the room, and I know you're in agreement that the work of the infection prevention consultant either needs a refocus, but certainly there's extra work for us to do. So I don't know if anyone's got any ideas as to how we can embrace that and what it is that we can shift down the priority list.
Susan, thank you for those, I think, on-the-ground comments. Many of you may not know, but Susan and I actually worked together 15 years ago, and I dragged her from the dark side of sexual health over to infection control. So I don't take credit for that, but I'm delighted to have seen you develop in your thinking around infection prevention, and I know that you want to work for a number of more years in this field. Personally, yeah, it's very difficult, but it's very exciting as well. And one of the best things about our job is that once you've done those basic things like hand hygiene and prevention of HAIs and the other things that we do, you can get into these more complex areas. And we have been very well supported globally by companies such as Nano helping us to understand this. And I'm fortunate to have seen peers doing similar work overseas, and there is now a much more global focus on this area, and it is complex. And it's often in places where we wouldn't traditionally go, but as you know, infection preventionists have a passport, a bit like a consular or an ambassadorial passport. We can get into places in hospitals that no one else can, and we should. And that's probably keeps it interesting. So someone else had a comment.
Yes, I'm just interested in your thoughts, Kath, about, thanks for a great presentation, but where we should be, or what influence we can have on the education of ultrasonographers, because they're obviously highly skilled people, but in our experience in the Illawarra, it was an eye-opening conversation for them when we started speaking to them around how they were reprocessing the variety of probes. And of course, the other people that are not ultrasonographers but do use probes a lot are our obs and gynae and midwifery people looking at early pregnancy screening and stuff. And those are as well as ED, those are the places where we have found lots of opportunities to improve, put it that way.
Yeah, I would agree with you, absolutely. And I had the very good fortune through Nano to do a webinar with the Ultrasound Society just about 2 years ago. It all blurs a bit. And I think the registration, I was astounded to see the registration for that webinar because you could see the numbers. It was several hundred people. And I'd never presented to that audience before, and they were dogged in wanting to know the information, and they were horrified that they may be inadvertently placing people at risk. So I'd say to you that now, perhaps better than any other time in Australia, we've got a strong relationship between ASIPSI and ASUM. Jocelyn, I think, who's senior or educational officer with ASUM, is very active sometimes on our list server and makes comments. So, it's a good time for those two groups to marry around this common problem. And you're quite right. When we look at, the range of specialties that are using ultrasound, so you've got gynecology, urology, hepatology, others, non-surgical groups, maybe, and I won't say maybe, I'll say yes, it should. Safe use of ultrasound probably needs to become a core skill for all people, even at intern level. And, maybe it needs to become a standard part of orientation in organisations. And it will require, perhaps it's a major project, a 3-month, 6-month project for you to go back to do a stock take. If I'd been sitting listening to me, once I woke up, what I would have done is, I'd be thinking, right, I need a checklist to go and look at all these departments. I need to understand where these devices are used. Oh, I need to develop some training materials. Feel free if any of this is useful to you. And, you would go through and do that just as you had to do for critical aseptic training. And I'm sorry, I am truly sorry that it adds yet another burden to your load, but this is a very important burden, and maybe there's some space or there are ways that we can make it not so much of a burden. Maybe there's a standard auditing tool, or if not, maybe I'll spend my period between Christmas and New Year developing one. Who knows? I'm not going to do that. So there's an opportunity, and maybe you and Susan can become the start of a special interest group for this. Who knows? But hopefully the lights come on for some of you today anyway.
Let's just ask one question. Sorry.
Oh, God, my old mate Sandra
Sorry,
Gordon.
sorry, Kat. And it'd be very remiss of me not to ask this question from my sonographer's point of view, is how long, once we reprocess process the transvaginal probe and pop it in the plastic bag, how long have we got before we have to reprocess it again for use, I suppose? So what's its shelf life once we've actually reprocessed it? Do we know that?
Yeah, I'm not going to answer. I can't give you a definite answer because I haven't looked and read the science around that. I'm very happy to go and try and find that science and try and interpret it. The other thing I would say that, you know, if you're using different manufactured pieces in that question, then, you know, it's a question to go and ask of the manufacturers. And, you know, it may be a question to put to the ultrasound group, ASUM, and it may be something that ASIPSI can answer. And, you know, why not post that question on the discussion forum and just see what sort of responses we get back? It'll also prompt me not to forget it. So I'm sorry I can't give you, you know, I don't have that degree of information right up here at the moment.
So probably just got time for one more quick question up the back.
Oh God, I can't even, I really can't.
It's Narelle.
What is this? This is old mates morning. Come on.
Sorry, Kath.
Give me a break.
I just think that my comment is that there's a lot of gaps that probably us as infection prevention control consultants can probably help to bridge with a lot of the technologies that are coming out. We've still got a lot of gaps where there's lovely ultrasound equipment, but there's no real ratification for how they're going to be processed. And I think when you go delving into your theatre areas, I know that with the sort of advanced surgery we do, or even just epi-aortic probes, a lot of them are used in sterile sites, but they still can't be sterilised. And sometimes it can just be infection control or how your product evaluation works, that you can actually be the facilitator to get those companies together to get things ratified, because it's often just doing the work. But it's all just going along for years and years without that happening, and we're probably really in breach of some of the guidelines, and it's just a little bit of work that has to be done, and a conversation and a connection and someone taking an interest, apart from not only the sterile end, but even simple things like a bladder scanner. How are they really being processed or looked after on a day-to-day basis?
Maybe it is time for a special interest group. But, you know, some people will have been creative enough and resourceful enough perhaps to have even solved that problem, not necessarily with science or science to prove that, but it's a very good point, Narelle, that you raise. And the other thing that I was thinking about then is that, you know, when we look at outbreaks, they're what we know has made it to the literature, but how much more is out there that has happened that we either haven't recognised as being ultrasound associated, and perhaps it has been all along. So maybe we have another conversation on this next year or years after. So again, thank you, and you'll be late soon.
So thank you very much, Kath. Just a couple of little points there. We're working with a group of infection control professionals in the US. Kath mentioned a couple of those individuals at the start, and we're actually developing a toolkit, so audit tools and similar things. So that will be available probably in the next couple of months. It will be available online for free. So I'll be very happy to link people up with that. On the storage issue, it's also something that we're interested in addressing and generating some data around. So the challenge is every setting is a little bit different. If the probe is wet when it's put into that bag, it has a very different storage time than if it's dry. And so I think obviously there's a lot of guidance for endoscopes, and that could be used as a minimum, because scopes, of course, you know, are very hard to dry, and they've got lumens and so on. So if you look at the scope literature and you start with that as being sort of your minimum, and then sort of go from there, I think that's a reasonable place to start for the moment. So thanks very much, Kath. Thank you, everyone, for coming. And I think we will provide the slides to everyone in due course too via email. So thank you very much.